And now we're on to lupus, the great imitator. Also as a point of interest, it means wolf in Latin. There are a phenomenal number of ways lupus can present, and it has the capacity to be a very different disease for many different people. That said, there are some consistencies, and this is what you'll be expected to keep in mind. The absence of these consistencies will likely help you keep lupus either on or off your differential. First off, some epidemiology, which is often very important for this disease. The vast majority of the patients are female, and between the ages of 14 and 45. Most of these women are African American, which also tend to have more severe cases. Though I won't say it's impossible, with a gender skew like this, I'll say that it's very, very unlikely you'll see a male with this disease in step 1, so have it in your mind every time you see a young woman with something that smells autoimmune in nature. The symptoms are very varied, and unfortunately there are a lot of nonspecific ones. The nonspecific ones include fever, fatigue, and weight loss. There are also certain conditions people with systemic lupus erythematosus are predisposed to. These include Libman-Sachs endocarditis, Raynaud's phenomenon, and hilar adenopathy, all of which can help you sort through your differential, but are not technically diagnostic criteria. In fact, the ones that you really need to know are captured in the mnemonic I'm damn sharp. This includes the immunoglobulins, which we'll discuss in some detail in a second, as well as a wide variety of symptoms, including the highly classic malar or butterfly rash. This happens over the face and cheeks. You also may see a discoid rash, anti-nuclear antibody, mucositis, neurologic disease, serositis, which can include pleuritis and pericarditis, hematologic disorders, arthritis, renal disorders, and photosensitivity. That most definitely will include a wide variety of organ groups, but you should pay particular attention to the skin, kidneys, the most common cause of death in people with the disease, blood, brains, and joints. The heart and lungs tend not to be affected directly, with the notable exception of Libman-Sachs endocarditis, as we mentioned earlier, as well as pericarditis, which again is often not a serious morbidity in the disease. Pulmonary complications include pleuritis, resulting in pleuritic chest pain, but often not with an acute presentation. Within other organs, there may be more serious sequelae. For example, in the kidneys, patients can have immune complex deposition. What type of hypersensitivity would this be? Type 3. Exactly. This type of renal disease can be very serious, often with a nephritic picture, and eventually leads to renal failure, a common cause of death in patients with lupus. Another unfortunate and common cause of death in lupus is infections, which patients can be predisposed to for a wide variety of reasons, from their underlying disease to the controlling medications and their immunosuppressive effects. In making the diagnosis, there are a number of serologies that are classically ordered to help confirm. The ones that we'll talk about here are ANA, anti-nuclear antibody, anti-double-strand DNA, anti-Smith antibodies, and anti-histone antibodies. ANA is probably the best known of all these, and while it has good sensitivity to help ensure all the cases are picked up in screening, it's not very specific, and further testing and clinical evidence is often needed. The second antibody, anti-dsDNA, is a much more specific indicator and usually indicates severe disease. Similarly, anti-Smith antibodies are very specific for the disease as well. If you're questioning if a patient has lupus and don't think you can go off of clinical evidence alone, ANA positivity is usually good to help guide your diagnosis, but dsDNA and Smith antibodies really confirm the suspicion. The final antibody discussed here is anti-histone antibodies, which are actually not related to lupus. They're related to a disease known as drug-induced lupus. It may have similar clinical features, but drug exposure is a crucial piece of evidence. The three drugs that are classically linked with this drug-induced lupus are hydralazine, used for severe hypertension, procainamide, an antiarrhythmic, and isoniazid, an anti-TB drug. They can be remembered with the acronym HIP, as in it's not hip to have lupus. But again, as the great imitator, it's important to recognize that antibodies from lupus can cross-react with other antibodies used in different diagnostic tests, causing false positives. The classic example of this is testing with RPR and VDRL. Do you remember which STI these tests are used for? Exactly, syphilis. The treatment of lupus is complicated. We'll discuss some of the important drugs in the pharm section of the chapter. Sarcoidosis is a disease that's marked by a widespread formation of what classically are described as non-caseating granulomas. Whereas the granulomas in diseases like TB are known for their caseous necrotic center, these granulomas appear cleaner without the same necrotic interior. On histology, there are two other important findings, Schaumann and asteroid bodies, which are worth remembering. As in lupus, this disease is also very common in black females. There are an incredible number of presenting complaints for patients with sarcoidosis, and as such, it would be worthwhile to try and get a sense of what all of them are. Nevertheless, in terms of answering Step 1 questions, if you see a vignette that describes a young African-American female with a respiratory problem, sarcoidosis should shoot pretty high up on your internal differential diagnosis. More importantly, there's a restrictive lung disease associated with sarcoidosis, and chest X-ray will classically show bilateral hilar adenopathy. Aside from this, other signs include Bell's palsy, erythema nodosum, and uveitis. Lab findings usually reveal two classic findings. The first is an increased level of angiotensin-converting enzyme. The second is an elevated calcium level, which occurs because the macrophages in the granulomas activate more vitamin D, leading to increased gut absorption of calcium, and thus hypercalcemia. The management of sarcoidosis is admittedly complicated, but what you should know is that patients who do appear to require acute treatment often benefit from steroids. You won't be responsible for understanding the intricacies of management, so just remember steroids. The next disease we'll discuss is polymyalgia rheumatica. It's a disease marked by pain and stiffness in proximal muscle groups and joints, namely the shoulders and the hips. There are often constitutional symptoms as well, including fever, malaise, and weight loss. The classic description is that there's muscle pain or myalgia, but there's no muscle weakness. It's most often a disease of older patients, greater than 50 years of age. The most important piece of this disease to recognize for your board exams is that it's often associated with temporal or giant cell arteritis. That means that patients may either present with both or have a history of one with a second presentation with the other. Either way, keep the two linked in your head because they do present together. There's no single lab finding that will help confirm the diagnosis, but an elevated erythrocyte sedimentation rate in an otherwise healthy patient may be a nonspecific sign of inflammation caused by this disease, and as a side note, also of temporal arteritis by itself. Creatine kinase levels are normal, as there is no breakdown of muscle itself, as will happen in diseases like polymyositis and dermatomyositis, which we'll discuss in the next fact. The treatment, as with most autoimmune disease, is steroids, namely prednisone, which can change patients' clinical appearance from phenomenal pain to virtually asymptomatic within a couple days. Fibromyalgia is an interesting disease. The typical clinical vignette consists of a middle-aged woman who complains of diffuse pain all over her body concentrated around a large number of points with no apparent physical cause. This is normally associated with several other symptoms, such as stiffness, paresthesias, sleep problems, and fatigue. It's thought to have a neuropsychiatric etiology. Because there's no as yet agreed upon cause, treatments vary considerably and will likely not be tested on step 1. The next two diseases are tough to keep straight, likely because they're fairly obscure, they sound similar, and they're always mentioned and taught in tandem. These two diseases are of course polymyositis and dermatomyositis. Polymyositis is a disease marked by progressive, symmetric, proximal muscle weakness, not pain. Classically, like polymyalgia rheumatica, it affects proximal muscle groups. The way to truly get at this diagnosis in part will require a muscle biopsy. The pathophysiology is that there's a CD8 T-cell induced injury to the muscle cells, revealing evidence of perifascicular inflammation, which means around the fascicles but not in them. Look for a younger person with shoulder weakness in vignettes. In dermatomyositis, the findings are similar, but the operative change is in the word, dermato, or the skin findings. Gottron's papules on the hands are the classic findings, and there also may be wearing of the hands that's described as mechanic's hands. Do you remember what disease we discussed earlier also presents with a malar rash in many cases? Right, lupus, the great imitator. It's important to know that patients may develop amyopathic dermatomyositis, meaning all the skin findings are dermatomyositis, but no damage to the muscles. The muscle damage may start late in the course of the disease or never occur. As we've discussed, you can make these diagnoses with biopsy, but usually the best confirmatory evidence is actually done by lab testing, where you often see increased creatine kinase, as well as increased aldolase. You'll also see a positive anti-Jo1 antibody. ANA can be positive in these patients, as this is one of the many diseases aside from lupus that have a positive ANA, but it's much less specific. The treatment, as usual, is steroids. There's a wide variety of neuromuscular junction disorders, but there are probably only two that will show up on the boards, and these are myasthenia gravis and Lambert-Eaton syndrome, sometimes known as Lambert-Eaton myasthenic syndrome. Of the two, the most common is myasthenia gravis. If you recall the normal physiology of the neuromuscular junction, first an action potential passes down a presynaptic neuron. As it approaches the end, it opens a voltage-gated calcium channel, which allows neurotransmitter vessels to be released from the presynaptic neuron. The neurotransmitter in the neuromuscular junction is acetylcholine, and as acetylcholine makes it to the motor end plate on the postsynaptic muscle cell, it binds to acetylcholine receptors and triggers an action potential to propagate along the muscle fibers, leading to muscle contraction. Do you remember the two types of receptors that are stimulated by acetylcholine? Right, nicotinic and muscarinic. In myasthenia gravis, patients have antibodies against the postsynaptic acetylcholine receptor, which causes them to reduce in number. This means that no matter how much stimulation comes from the nerve, it becomes difficult to cause contraction. These patients then end up presenting with difficulty contracting muscles that work frequently, classically the eyelids and extraocular muscles, causing ptosis and diplopia. Generally, they may feel weak as well. If patients continue to work out the muscle, they have more and more difficulty using the muscle. If you think about it, this makes sense because the acetylcholine receptor is not responding to signals from the presynaptic neuron, and no matter how hard you try, you can't get levels of acetylcholine to increase enough to cause steady contractions. In terms of clinical vignettes, you'll want to look for a patient, normally female, who complains of feeling weak and having trouble seeing, which gets progressively worse throughout the day. Normally, the acetylcholine that's released into the synaptic cleft is broken down by acetylcholinesterase quickly. If you inhibit the enzyme, though, you can effectively increase levels of acetylcholine in the cleft and inadvertently drive more muscle contraction. This is exactly how you confirm the diagnosis of myasthenia gravis, by giving an acetylcholinesterase inhibitor called edrophonium and seeing if symptoms improve. One important board's relevant fact is that both of these syndromes have a paraneoplastic relationship with particular tumors. Myasthenia gravis tends to occur in patients with underlying thymomas. In contrast, patients with small cell lung cancer are more likely to develop Lambert-Eaton syndrome. The latter syndrome is quite different from myasthenia gravis. Here, the problem starts earlier than the acetylcholine receptor. Antibodies are formed against the presynaptic calcium channels. Therefore, when patients send a signal to contract, the action potential travels along the neuron, gets to the voltage-gating calcium channels, and causes them to open. But since they're getting impaired by these antibodies, only a small amount of calcium is allowed to enter the presynaptic neuron to allow for neurotransmitter release. Since not enough calcium enters, not enough neurotransmitter is released, and a weak contraction is elicited. However, unlike myasthenia gravis, if more and more attempts are made, more signals are sent, more calcium is allowed into the presynaptic neuron, more neurotransmitter is released, and in the end, stronger contractions are the result. The exact opposite of myasthenia gravis, really. Also, when you give these patients drugs like edrophonium, you don't expect much of a change at all, as this isn't the problem underlying their disease.